I think the reverse shoulder, you have to be careful because it's not only bony operation, it is a soft tissue surgery as well. With that background, see this patient, 65-year-old lady, proven known osteoporosis, T-score is over 3, -3, and she was not on treatment for that. But she had a recent fall and sustained left shoulder injury. She sustained a 4-part displaced proximal humerus fracture. And this was the original X-rays she had. It was treated elsewhere. So this was the CT scan findings, available scan findings. Now this is the plain X-rays, CT. And
this ARS doesn't tell us the numbers, otherwise I would like to know. Some people have probably suggested nailing also.
6
it doesn't tell you the number because...
I think the 6 was hemiarthroplasty.
Yeah.
Okay, so any comments on that?
I can see you have a ceramic head.
Yes.
Glenosphere, that's all I can see. The rest looks good.
GTLT excised, I suppose.
So there's no lateral, just only available X-rays I'm showing. There is no true lateral X-rays, very important, yes. And anything else to make? So we move on. So this patient...
this glenoid, what do I see is an anterior to the glenoid. What's that? Yeah, that line. I mean,
sorry,
where is this placed?
Pointer? You have a point? Yeah. So this is the 1 month post-operative. I will come to that. When she came to see me, it was like 5th month with axillary nerve weakness as well, some weakness of deltoid and some loss of sensation. So, but this is the 1 month postoperative. Any guess about the what system being used here? Yeah. Okay. Anybody has experience with that system? Okay. 2 months postoperative. Series of X-rays. The surgery was done by a hip and knee replacement surgeon. Just additional information. So that's a 2 months post-operative.
It's got a polygleno.
Yeah. See what you see here. See, you see like something like a stump, but this is the base plate.
Yeah.
The
Yeah.
glenosphere is poly
get the
here.
Poly, but this is lateralized like way too much.
Yeah.
So is there an option to or is it compulsively so much lateralized?
It is not.
Huh.
It is not, but there is an option of humeral lateralization in that
Yeah.
system. +3, +6 like that it is.
So this is like the DJO, is it?
This is a system called Miroi. I'll show you in a minute. So this is the 2 months post-operative, but as you see, the problem is with the tuberosity. This is what I think Ashish started to mention, the first place. It is not a bony surgery, it's a soft tissue surgery. Tuberosity has to be restored. 4 month post-operative, she had this X-ray, seen the surgeon in pain, but sent to physio. And then this is at 5th month post-operative, severe pain, cannot move the shoulder, and that point she came to see me. So that's the range of movement she has, and that's the current X-ray. So I'm just clearing that this is like a trough, so you could see that there is no bone proximally, which we don't have any control. We have to accept that. And then I just knock that thing out, liner, and that's the liner. It doesn't come in 2 sections, it comes in one big titanium prosthetic piece. So next is the poly, you can see the polyglenosphere. My concern is also that, if you do a lot of dissection or thing, you might scratch or damage the poly more. In the regular scenario, we replace the humeral side poly. So we damage it, we remove it, we can put a new one. But here, if you do the glenosphere poly, any damage, you had to do few more changes, but you have to be careful in not doing much dissection to that. So, and I couldn't change the glenosphere size, so I just put a bigger maximum size what the company has, and luckily got out of the stem was very well fixed. And the other option, I have explained to the patient that we have to take all the prosthesis out and do the system which I do regularly so that I can have complete revision. But complete revising the humerus is the pain in 5 months' time to split the proximal humerus, take it out, put a new prosthesis, reconstruct on it. The results won't be that good. So try to do that. Nothing. I just left it. The question is whether you could say that you could go in and dissect it out free or anything. There's a possibility option I thought of, but yes, there will be some injury. I just reserved it for a second stage, just to get the stability first, then get the guys to come and do that. Yeah. So that's the only good thing is that it is a very tight spaces, so it went in very tight. So I thought, okay, that's good, stability-wise. That is what it looks like. With this system, if you look at the true AP X-ray, it should look like that. So that you will see.
But I asked him
here.
before.
Yeah, I didn't. What I decided to do is that either you do the sphere or the poly, or you have to take out that.
Ram.
So there is no, unless it is too much.
Ram.
Yes.
Just go back to this slide. Okay. Now tell me the rationale that you have kept I'm talking about this system. You kept the proximal humerus medial and taken the shaft laterally. It doesn't restore the length tension relationship of the rotator cuff. What we should be trying to do, like in Zimmer Biomat, we are lateralizing the humeral tray by 3 millimeter or 6 millimeter, the offset ones. Yeah. So that we can take we can increase the length of the remaining rotator cuff, and this is working exactly the opposite way. So it's a very, very weird kind of situation.
So I just put it in sling for first 4 weeks. When you do for any revision of dislocation reverse, you have to put in a sling to let it heal. So sling for 4 weeks, then started elevation exercise. So this is her at the follow-up at 6 months. It's only operated 6 months ago, and that's the active elevation.
So what is the status of the deltoid now?
Deltoid is recovered. Gambling won't. So that's the follow-up, internal rotation, and external rotation is restricted, but she's got no pain. So I think we have only 1.5 minute. Just to show some literature, this is the...
Ram, I have a question. What was the lengthening of the arm?
Total length of the
arm.
Total lengthening.
And what is permissible limit according to you?
Oh, generally?
In general.
Generally asking. Generally, I think usual reverse shoulder lengthen the arm by 2 centimeters. 2 centimeters. If you do the regular 155.
Because this appears far more than that. That could be the reason.
See, I increased the spacer line 10 millimeters. So already I have increased. So,
Dr. Ram, I think you are very...
Oh yes, Sujit. Yes.
Yeah, I've been doing this Mirai for some time. The advantage is that you have an option to switch from total shoulder to reverse.
Yes.
Anatomy to reverse. It's a metal
Dr.
back shoulder.
Sujit, we would like you to talk about this prosthesis starting from inlay, onlay, medializing versus lateralizing, so that the people know that as compared to the other common reverse shoulder prosthesis they use, how different is it? Because we have got a visual slide of it and they might be able to understand it better.
I'll start with the principle. It works in the principle that total can be converted into reverse if in case the rotator cuff starts dysfunctional after some time. So you have a metal back on the glenoid. I had presented in the Valdezia Dr. Ashu Babulkar's conference where you have a total shoulder with a metal back.
Okay.
But the problem with metal back is you cannot increase, the poly thickness can maximum be 3 or 4 millimeters, maximum 6. And the wear rate is high if you put a poly on the metal back. So here they have done a reversal of the bearing surfaces. So they use a titanium on the glenoid and a poly on the humeral head. So that's the same where when you do a reverse, you just reverse it again. You have a head glenosphere which is on the glenoid, which is poly, which is vitamin E poly, and you got a cup which is metal.
Yeah.
And you have an option to lateralize the glenoid. The metal back can be lateralized by using a bone graft there, the bio RSA.
Yes.
That can be done, and they have this peg option as well as a screw option.
Yes.
So the PEG integrates much better. They have this tracer technology, as they call it, which is like the titanium or trabecular metal, which has the option to integrate much better the central peg as well as the two screw options, and it is anatomical. It's not circular.
See, the
like
base-
most with
base
other
plate
systems.
So
was very-
it is a medial humerus and lateral glenoid at best.
Yeah.
Yes.
At best.
Yes.
For lateralizing purposes.
For lateralizing. You can lateralize the glenoid. You can lateralize the glenoid.
But the glenoid, not the humerus. Because humerus is already offset.
Already opposite, yes.
See, I think that's what first slide I said. You had to familiarize with the system you want to use because there is so much difference in all the reverse shoulder systems. And second, as the prosthetic system, we are not blaming any prosthesis here. The prosthesis is good performance for primary reverse shoulder, that's not a problem. But here the issue is that lack of understanding from the surgeon's aspect in dealing with the prosthesis. And second is lack of understanding of principles of restoring stability to the shoulder replacement for fractures. I think those two are the key factors which I would like to highlight. And third thing is that when the patient comes with the dislocation, now the prosthetic options we should have. Otherwise it is an issue, okay?
Especially reverse in fractures is high complication
High
rate. So it has to be done by somebody who has done enough in the past and.
But not only this system, in the same month I operated 3 dislocated reverse. One from each company.
Can I put in a point that if it was a primary being done by you and the same thing happens, when you do a trial, it dislocates, would you increase the thickness of the humeral component or would you lateralize the
glenosphere?
Yes.
If the glenosphere, the biggest size, is still I think believe it is the biggest stability for a reverse shoulder system.
Not the size of the glenosphere, would you lateralize?
Lateralize,
it?
yes.
You add a bone graft there.
Yes.
Again, that depends on what system you are
What
using.
the-
Some
what the
systems
problem
have
is.
very severe limitation on lateral glenoid. But Sujit, you told us all the beautiful points about the model. Tell us the bad points.
So we can see these couple of slides. We just put, to summarize, the dislocation rate is around mean 5%, range from 3 to 30. Poor deltoid tensioning is the reasons for dislocation. Second, weak deltoid, injury, rupture, acromion fracture, etc., or mechanical impingement. And how to avoid dislocation? Optimum deltoid tension, avoid superior base plate tilt, avoid too much medialization of glenoid, avoid impingement, repair both tuberosities in fracture, especially subscapularis preservation or repair in elective conditions, and final check by putting the patient at risk. And this is like a flow chart to say an unstable RSA, how you get to sort it out. If you look at that, either you have a humeral shortening or humeral medialization. Accordingly, you do a larger glenosphere or thicker PE. We have succeeded with this one, but not always. Sometimes we might need to do more. Thank you.
Ram, just here. Using 145 vis-a-vis 155. Any choice there to prevent dislocation in a trauma situation?
Yeah. I was in Rome last week. We had a big debate about 135 or 145 or 155. I think the world is settling for 145. And with that we have been using quite a long time in India. I think the notching is much higher with 155 degree prosthesis.
That was the
And
original
range of
Gremo.
rotation is better with when the angle is less. So the
Which is
trend
a
is towards using 135 or 145.
Which is a bigger enemy in trauma situation, dislocation or notching?
In trauma situation, I think if you restore the length and repair the tuberosities, I don't think we need to really use concern about the instability. You can very well use the 135 or 145 prosthesis.
So that 135, 145 has zero impact on dislocation. It is all surgical technique and balancing. So you could subscribe to 155 and still not have a dislocation.
So most of the literature doesn't differentiate between a 135 and a 155.
I think the answer will be found whether you have a better tuberosity healing rate in 155 or 145.
Both have a good, they are much better than
but
hemiarthroplasty.
not statistically significant, so the technique has to take priority.
But with the 155 degree, in the long-term outcome, you have more notching. And number two, Laurent Lafosse published his series now recently presented with the lack of internal rotation.
See,
the rotations are much better.
With the lateralized.
The rotation is much better when the angle is less.
Yes, I think meta-analysis has just been published. Don't remember just now that 145 gives you a better outcome.
So in between.
As compared to in.
Okay.
Dr.